Good afternoon everyone and welcome to my channel. أهلا وسهلا فيكم جميعا على قناتي. اليوم حبيت إني أتكلم بهاي السلسلة بهاي الفيديوهات على أكثر مشكلة بنواجهها كأطباء أسنان وبالمجتمع بشكل عام اللي هو تسوس الأسنان، ولكن حبيت إنه نشرح الموضوع من جهة بيولوجية أكثر، نفهم علمية أكثر، نفهم شو مسببات تسوس الأسنان وشو هي الطرق الوقائية اللي ممكن نستعملها لحتى ما نوصل لمرحلة الحفر، وشو هي التدخلات الوقائية اللي ممكن طبيب الأسنان وممكن المريض أو المراجع نفسه إنه يلتزم فيها لحتى نحاول نقلل من التدخل الجراحي بقدر الاستطاع. Today I really like to start this series by speaking about the most fundamental and the everyday problem we as dentists face every single day, which is dental caries. However, I like to emphasize today about the importance of preventing dental caries, and I'd like to emphasize on the idea of shifting toward preventive approaches rather than the classical surgical method in treating such dental caries. I'd like to explain what is dental caries from a biological view in order to understand what are the factors that cause dental caries and what is the biology behind the caries formation in order to appropriately intervening with the least invasive procedures possible. Okay, let's keep things simple and start with the basic terminology by defining what is dental caries. So, dental caries is a preventable disease of the mineralized tissues of the teeth with multifactorial etiology related to the interactions over time between different aspects such as tooth substance, certain microorganisms, and dietary carbohydrates producing plaque acids. So, ما هو تسوس الأسنان؟ تسوس الأسنان بكل بساطة هو مرض مزمن، ولكنه ممكن إنه نتجنب هذا المرض of a mineralized tissues which of the teeth, but with many causes. Okay, caries is a multifactorial disease. Okay, so caries is not due to bacteria alone. It's not due to the sugary food alone. It's an interaction between different factors playing all together, working all together to produce caries, to end up having caries. So, in order for caries to occur, we need different factors. First, we need microorganisms. Okay? These microorganisms, these bacteria, are going to occupy and are going to live on the tooth. Yet, I do need food. I do need sugar. I do need sticky food that stays for a prolonged time on the tooth surface in order to end up by demineralizing the tooth, and we end up having caries. Okay, so but the good thing is that it's a bidirectional disease. That means we can prevent caries, we can stop caries from happening, or if we try to disrupt this cycle. Okay, so for every patient has his or her own pathological and protective factors. What we are trying and what we are aiming to do in this lecture is to, and in the dental practice in general, is to shift the trend toward the protective factors, and we want to disrupt all and stop the pathological factors. Okay, moving on to discussing what are the consequences of dental caries. The most obvious and that's the main issue and the main concern for the patient is pain. Pain that interferes with the daily activities such as eating, sleeping, playing, and attending school. Sepsis as well. The need for emergency visits and hospitalizations. The need for extraction and space loss, and in terms of, if we're speaking about, for example, pediatric patients who are not cooperative, sometimes there will be a need for GA and increased risk and even increased treatment cost. It also leads to a diminished oral health-related quality of life, pain, poor appetite, disturbed sleep, speech problems, self-esteem. If we speak in terms of the effect of caries on the general health, we can see that the patient, especially kids, have delayed physical growth and insufficient weight gain, missing school days and poor school performance due to pain and due to suffering of caries, the possible disruption of intellectual development. This is very important, especially in pediatric patients, as we all know that some letters and speech is affected by teeth, especially the anterior teeth. So if there was extraction, if there was a space loss, it all plays a role in the development of a speech and the development of the good letter sounds. Also, exacerbation of problems in fragile special need children and high caries risk. So, because of all of these consequences of dental caries, we need for prevention. We really need to stress out on prevention of caries rather than treating caries. By understanding the multifactorial nature and the dynamic disease process, as we said, that caries is not due to, it's not a cause and effect. It's not that when you eat sugar, you'll get caries. It's a bidirectional disease, preventable, and it is multifactorial. You need all the aspects, all of the pathological aspects to work together to end up having caries. So it's a dynamic disease process. You need, for example, poor saliva, sticky food, staying on the tooth for a long period of time. You need specific microorganisms such as the Streptococcus mutans, and you need the host or the tooth. They all play together in order to end up with a caries. So we really need to stress on the topic of moving and shifting towards the non-operative preventive caries management rather than stressing on the operative, the surgical approach in dealing with caries. يعني لازم كل أطباء الأسنان ينقلوا أو تشفت الكاريز مانجمنت ل يعني نتوجه، خلينا نحكي، للطرق الوقاية من تسوس الأسنان أكثر من إنه دائما نستعمل الدريلينج والتيث فيلينج. So why should we move from, and we should move away from the operative approach? Now the classical surgical restorative approach اللي هو operative approach اللي هو التدخل الجراحي في معالجة تسوسات الأسنان, it removes only the carious tissue but does not cure the disease. نحن بس مؤقتا عم نشيل التسوسات ولكن ما عدلنا نظام المريض نفسه, ما غيرنا الدايت هابتس, نوع الأكل, طريقة التفريش, نظام حياة المريض نفسه. لهيك احنا we're just temporarily removing the carious tissue, but we're not curing the disease اللي هو caries. It may result in several replacement restoration يعني it's a cycle, repetitive cycle of repeating the restorative cycle. 71% of the restorations are performed on previously restored teeth, with secondary caries being a major problem, according to one study. So this current surgical model التدخل الجراحي في تعاملنا مع التسوسات الأسنان does not fully address the multifactorial nature of dental caries. ما بيراعي فكرة إنه تسوس الأسنان هو أكثر من عامل بيشتغلوا مع بعض لحتى ينتج عندي تسوس الأسنان، هو مش بس cause and effect. This model often results in unnecessary removal of tooth structure, which can impact negatively on the general health and the quality of life, and can impose even extra cost on patients and even on the government as a whole. So, as we had previously mentioned, we should change from the idea of extension for prevention to extension of prevention. Okay, you don't need to drill more in order to prevent caries, but we need to prevent drilling from in the first place. Are we ready to move to this non-surgical, non-operative approach? Yes, of course we are. But this approach should be done in the appropriate stages of the lesion extent and patients who respond to the advice on recall frequency and preventive behavior. So in this approach, we do really rely on the cooperation, the motivation. قد المريض متعاون لحتى نحاول بهذا الapproach. What are clinical considerations in preventive dentistry? First, preventive dentistry requires a special clinical and diagnostic skills for early detection. We really need to identify the caries in the early stages لحتى نوقف التسوسات الأسنان حتى قبل ما تتطور وتوصل لمراحل where the only solution is drilling. الحل الوحيد بيكون في هاي الأوقات لما تتطور الليجن كتير إنه يكون إما مثلا drilling أو علاج عصب أو حتى extraction. It requires regular recall visits, so it's somehow time consuming. يعني إحنا we do need a motivated خلينا نحكي patient who is able and who is willing to come every, for example, 4 to 5 months for regular checkups in order to diagnose caries and detect caries early. But there are great rewards for the patients. يعني despite all of the time consumption and the cooperation and the multiple visits, it does promise the patient with good and great reward because it avoids the irreversible restorative cycle and the associated costs. So by going toward preventive dentistry عم نخفف التكلفة العالية على المريض وعم نخفف فكرة إنه السن خلاص ما في رجعة منه، لازم له علاج عصب أو لازم له حفر. فإحنا بنكون لسه بالمراحل الريفرسبل، المراحل اللي ممكن نتدخل بدون الجراحة، بدون الدريلينج والحفر والoperative work in general. So what dentists are now trying to manage caries with اللي هي فكرة caries risk assessment. Okay, so basically what we do as dentists that we categorize the patients. بنصنف patients ل for example 3 مجموعات. مجموعة low risk patients, moderate risk and even high risk. وبيتم التعامل مع التسوسات أو بتم التعامل مع كل مجموعة من المجموعات بطريقة مختلفة عن المجموعة الثانية based على الريسك لهذا البيشنت. So the modern approach for caries risk اللي هو ال CMBRA, caries management by risk assessment. This is an evidence-based patient-centered management. يعني we don't treat ما بنعامل كل المرضى بنفس الطريقة، ولكن each patient depending on the risk factors, depending on the risk assessment is being treated in a specific way which may differ from another patient. So this type of assessment, it recognizes the multifactorial nature of the disease, and what we're trying to do is to balance between the pathological and the protective factors. As we said, what are some protective factors to prevent caries? We do need adequate saliva flow, fluoridated water, for example, professionally applied fluoride rinse, xylitol gum, mint, and we try to decrease and diminish the pathological factors such as visible plaque, removal of plaque, removal of calculus, inadequate saliva, acidic beverages, deep pits, deep fissures, uncooperative patient, not motivated patients. So all of these factors, they play a role in increasing the risk and increasing the probability of caries formation. It is a minimally invasive correction action if needed. يعني we only intervene minimally in order to stop the progression of the lesion and stop the progression of the caries. And assessing caries risk is very important for all patients, and the process has to be repeated at different intervals. For example, a patient who, for example, started as a high risk after treatment and after time, he or she may change toward the moderate risk or even low risk. Okay, it depends on many factors. If we were able to modify such factors, and it depends on the cooperation as well. So in this table, we can see how can we assess pediatric patients from the age between the ages 0 to 5-year-old in terms of the caries risk assessment. We can see here that any child that has greater than 1 decayed or missing or filled surface is a high-risk patient. Okay, any child that has an active white spot lesion or an enamel defect is also considered to be high risk. Child that has elevated mutant streptococci levels is also considered as a high-risk patient. However, if we speak about the protective factors, a child who receives optimally fluoridated drinking water or fluoride supplements as tablets is considered as a low risk. The child who has who brushes his or her teeth daily with fluoridated toothpaste is a low risk patient, and a child receiving topical fluoride from health professional and dentists is considered as a low risk patient, and child who has regular dental care is also considered as a low risk. If the patient or the child has greater than 3 between meal sugar containing snacks or beverages per day, this patient is considered to be a high risk patient. Okay. Some also consider the low socioeconomic status as a high risk patient. If the mother or the primary caregiver has active caries, it tells a lot about the caries risk assessment of the child, okay? Because you can tell from the dietary habits, from the oral hygiene, and the number of microorganisms that the mother have or the caregiver has, it tells somehow about the caries risk of the child. Moving on to the caries risk form for children above, let's say, 6 years old. We can see from, as a dentist, these are the clinical findings that we look at in our clinic. If the patient has greater than or at least one interproximal lesion, that means class 2s, for example, this is considered as a high risk patient. If the patient has active white spot lesions or enamel defect, this is a high risk patient. Patient that has low salivary flow is considered as a high risk. Patient who has defective restorations is a moderate risk patient, and patient who's wearing any intraoral appliance, so for example, ortho appliances or let's say RPDs or whatever the intraoral appliance that the patient is wearing, this is considered as moderate risk, as these intraoral appliances tend to accumulate plaque more. Okay. Okay, so we spoke about the importance of prevention and why should we shift toward prevention rather than the surgical approach in dealing with caries. Now we'll speak about the levels of prevention. Dentists categorize prevention into 3 levels. Okay, the primary prevention, secondary prevention, and the tertiary prevention. فغالبا احنا بطب الأسنان بنقسم الوقاية لمراحل. في المرحلة الأولى اللي هي ال primary prevention. In the primary prevention, what we're trying to do is that we're trying to prevent the occurrence of the disease or the initiation of the disease. So we're trying to do our best in order to prevent the beginning, to prevent the initiation of the disease. كل الطرق الوقائية بشكل عام اللي بنحاول نعملها لحتى نمنع حدوث أو بدء هذا التسوس أو هذا المرض، بحالتنا التسوس هو. في examples، في كتير أمثلة على ال primary prevention، مثلا ال good oral hygiene. We're trying to maintain a good oral hygiene, plaque control, good plaque control for example. بنحاول إنه نحسن من العادات الصحية تبعت المريض، for example the diet habits، شو هي السناكات، شو هو النظام الغذائي اللي ماشي عليه البيشنت، كيف بفرشي أسنانه. حتى مثلا في أشياء، في إجراءات يعني بيتم عملها بالعيادات الأسنان اللي هي البيت أند فيشر سيلنت. هاي مادة بتنحط بالديب بيتس والديب فيشرز حتى إنه تمنع تراكم البلاك وتمنع تراكم الفود in such deep areas that are sometimes inaccessible by toothbrush, in order to prevent the progression and to prevent even, let's say, the initiation of caries. Moving on to the secondary prevention. المرحلة الثانية في prevention، هون في هاي المرحلة disease had already started، disease بدأ، وهلأ بس اللي لازم نعمله إنه نوقف أو نحاول إنه نمنع التقدم لهاي الكاريز أو لهذا التسوس. So we're trying only to prevent the progression, or in cases where the disease had stopped already, we are trying to prevent the recurrence and the recurrence of the problem or of the disease. Examples على بعض الأمثلة على secondary prevention، في عنا PRR which stands for the preventive resin restorations أو pulp capping. Okay, we're just trying to prevent and decrease the severity of this disease, let's say. Moving on to the tertiary prevention. آخر نوع prevention. هون بهاي المرحلة إحنا خلاص caries أو disease had already progressed, have already caused disability. بس إحنا, for example, caries had caused a cavity, a big huge cavity in the tooth, and the tooth has خلاص يعني started to decay, and we need a definitive treatment such as a root canal filling or a crown or maybe a filling such as amalgam filling or composite filling. So in this stage احنا فقط عم نحاول to rehabilitate the patient, بنحاول انه نخلي البيشنت يتأقلم مع الضرر اللي صار بسبب تسوس الأسنان في حالتنا وفي مثالنا هون. فبس بنحاول انه نعطي البيشنت حلول لحتى نحاول انه نخلي هذا السن يدوم في فم المريض لأطول فترة ممكن. We're trying to rehabilitate the patient in order to let him accommodate with the new disability, and we're trying to let this tooth live and stay in the patient's mouth for the longest time possible. Okay? Moving on. So, we've spoken about the levels of prevention, and now we'll talk about what are the ways of prevention. Okay, كيف الآن ممكن نعمل وقاية لتسوسات الأسنان? What are the methods in order to control caries يعني أو to prevent caries؟ فإحنا هون عم نحاول إنه إما نعمل وقاية لحتى إنه نمنع تكون التسوسات في الفم، أو إذا حصل تسوسات كيف ممكن نتدخل بأقل طريقة يعني أقل invasiveness بألطف طريقة ممكنة وما نسبب ضرر أكثر وما يكون الإجراء جراحي بشكل كامل. يعني في إجراءات ممكن أنها توقف أو تحد من تقدم هذه التسوسات أو this lesion. Okay? So we're trying to either prevent caries in this approach, or we're trying simply to intervene with the least invasive procedures ever. So, as we said, that caries is multifactorial. So, it is caused by different factors playing all together for producing or in order to end up with caries. So, it is logical that there should be more than one way in order to intervene to prevent or to stop caries. Okay, so there are 7 ways, as you can see here. There are 7 points that we could intervene and prevent caries from occurring or progressing. So we'll discuss each one briefly. First, we'll discuss, so there are 7 points. The first point here, as we can see here, is the primary prevention. And what does that mean? Is in this aspect, or here, we are trying to prevent the acquisition of cariogenic bacteria from the mother or from the primary caregiver. As some studies have shown that the mother or the primary caregiver is the major source for the microorganisms such as Streptococcus mutans. The earlier the acquisition of such microorganisms increases the risk of early childhood caries and future caries, according to another study. So what are some of the maternal factors أو بعض الفاكتورز اللي بتكون موجودة بالأهل اللي ممكن it affects الترانسميشن وit affects إنه الطفل يكتسب هذه البكتيريا أو يكتسب هذه المايكروأورجانيزمز. أول شيء maternal salivary level of Streptococcus mutans. The maternal oral hygiene يعني it tells us a lot. It tells us a lot about the mother's motivation, the dietary habits, the education, and the socioeconomic status of the mother also plays a role in the caries risk assessment of the child, the magnitude or the frequency of the inoculum, and even breastfeeding. هلا some studies shift toward the mother or the parent in general. It shifts toward maternal interventions such as, for example, chlorhexidine, fluoride application, xylitol gum, educating the mother more يعني in terms of the oral health education. However, there is no consistent finding regarding the caries reduction in such aspects, in such methods. الطريقة الثانية وهي الطريقة اللي خلينا نحكي واقعية أكثر، أو الطريقة اللي ممكن إنه يلعب فيها دور المريض، يساعدنا فيها، بيكون الدور الأكبر على المريض which is the plaque control، اللي هو قد ايه المريض متعاون، قد ايه المريض بيعتني بأسنانه بشكل عام، لحتى هذا بيعكس على الطرق الوقائية وبيعكس على الريسك assessment للبيشنت نفسه. So it is a sensible approach, let's say, to disturb the bacterial communities. Here we are trying to arrest enamel or open dentinal lesions even. So as you can see in this picture, the gingiva is inflamed. يعني أول شيء بيخطر بالنا في هيك clinical picture bad oral hygiene, let's say. في عنا الgum inflamed، في عنا هون swollen gum as well، في plaque، في calculus. يعني it's a good area، هو مكان هذا كتير كويس للبكتيريا to grow. فبالبلاك كنترول بطرق توعية المريض عن نظافة الأسنان وتفريش الأسنان، احنا هون عم نحاول انه نحد من البكتيريا ونحد من الفاكتور اللي هو الأكل اللي بضل عالق ومتراكم على سطح الأسنان مع البكتيريا الموجودة باللعاب والفم لفترات طويلة، فبالتالي بيأثر على اللثة وبيأثر على الأسنان بحد ذاتها. هلأ البلاك كنترول في كتير طرق. There are a lot of ways to manage or to control plaque. First, we have the oral prophylaxis, and this is يعني supported or it is given by the healthcare providers, dentists in general, or hygienists, to decrease the formation of dental plaque by careful polishing, scaling. دائما بننصح المرضى إنه خلال كل 6 أشهر، خلينا نحكي إلى سنة، إنه يعملوا تنظيف للترسبات اللي عالقة على الأسنان. هاي الترسبات بتكون hard، بتكون قاسية، فما بتنشال بتفريش العادي. كل 6 أشهر إلى 12 شهر إلى سنة يعني تقريبا تنشال هاي التكلسات عند طبيب الأسنان أو الدنتال هايجينست، لحتى نخلي سطح السن يعني نمنع من تراكم البكتيريا أكتر فوق هاي الكالكولس. تاني شغلة وأهم شغلة برأيي اللي هي التوث brushing. أوكي، إذا كنا عم نتكلم عن البيدياتريك patients, so here we are interested in educating the caregiver and educating the mother or the father. أوكي، الفكرة بالتوث brushing إنه إحنا عم منشيل أو عم نمنع البكتيريا ونشيل طبقة الأكل الباقي على الأسنان ميكانيكيا. and كمان في عندها دور ثيرابوتيك، لأنه معجون الأسنان يحتوي على الفلورايد، فهو mechanical and therapeutic effect. في عندي كمان anti-plaque ingredients such as the TP in the toothpaste, okay, such as the triclosan. Whenever a patient can access and disturb the biofilm, a filling is not needed. So دايما طالما انه هذا السن عم يوصله فلورايد كويس، عم يوصله لفرشاة الأسنان، في غالب الوقت هذا السن ما رح يحتاج لأي حشوة، ما رح يصيبه أي تسوس. Let's talk a little bit about toothbrushing. نعطي معلومات خفيفة بسيطة عن تفريش الأسنان بشكل عام. هلا the value of toothbrushing in caries prevention lies with the regular topical application of fluoride. أنا اللي بيهمني بالفرشاي إنه ميكانيكيا يعني إنه عم نشيل طبقة البلاك، تمام، وهذا بفعل إنه الشعيرات عم تيجي على السن وتشيل طبقة البلاك أو طبقة الأكل مع البكتيريا من اللعاب مع بعض مكونات اللعاب. كمان اللي بيهمني إنه يوصل للأسنان الفلورايد. مادة الفلورايد بتساعد على إعادة معدنة الأسنان، ف it helps in remineralization. طيب شو هو البروتوكول للتوث بريشنج؟ شو هي الريكومنديشن للتوث بريشنج؟ شو هو البروتوكول لتفريش الأسنان؟ ننصح المرضى دايما إنه to brush teeth twice، تفريش الأسنان أقل شيء مرتين في اليوم باستعمال أي معجون أسنان يحتوي على فلورايد، يفضل at least يكون 1000 part per million of fluoride. and to ensure that إنه هاي الفرشاة الأسنان توصل لكل أسطح السن، تمام؟ هاي هي المشكلة اللي كتير مرضى بيعانوا فيها، إنه فرشاة الأسنان ما بتوصل لكل المناطق خاصة الخلفية للأسنان، وبنفس الوقت مش كل أسطح الأسنان توصلها الفرشاة. دائما ننصح المريض to spit out the toothpaste and avoid rinsing out with water. يعني يفضل إنه ما يتم تغسيل بعدها بمي، يعني بس إنه يتم إنه يتف المريض التوثبيست، يحاول يتخلص منها لحتى إنه نحافظ على الفلورايد يضل ملتصق على الأسنان لأطول فترة ممكنة. When should patients start, or let's talk about children. When should kids start toothbrushing? دائما بيسألوا المرضى هذا السؤال، إنه متى لازم نبدأ بتفريش الأسنان للأطفال. As long as the first tooth had erupted, then toothbrushing is a necessity. حتى لو even if it was not يعني with a toothbrush and with a toothpaste، بس لازم at least we wipe the newly erupted incisors for example or the molars with a wet gauze بقطنة مبلولة، تمام. من أول ما يبدأ طلوع أول سن للطفل لازم إنه يتم تفريش أو تنظيف هذه الأسنان، حتى لو ما كان بفكرة إنه فرشاية ومعجون أسنان، حتى لو إنه فقط قطنة مبلولة يتم مسح الأسنان حتى بس نشيل طبقة البكتيريا مع الأكل اللي بتراكم على الأسنان الأطفال. طبعا أي الطفل أقل من عمر 2 سنين ما بننصح إنه نستعمل مع toothpaste أو معجون أسنان يحتوي على الفلورايد. Then we need to go through the interdental cleaning aids. شو هي السبل، شو هو التولز الaids إنه ننظف ما بين الأسنان، لأنه زي ما بنعرف إنه في عندي tight contact، الأسنان بتكون ملاصقة لبعضها البعض، فصعب إنه شعيرات فرشاة الأسنان تدخل ما بين هذه الأسنان. لذلك دائما بننصح المرضى to floss خيط الأسنان. ليش؟ to remove the plaque، نشيل هذا to remove this plaque and the dislodge irritating matter. هلا it does not matter إنه سواء كان بشمع أو بدون waxed or unwaxed. متى نحتاج أو متى بيكون لازم إنه نستعمل dental floss؟ anywhere where there is a tight contact between the teeth and the interdental papilla fill the interdental spaces. في بعض يعني هذا هو البروتوكول العام. This is the basic oral hygiene instructions اللي لازم كل حد وكل شخص يتبعها باستمرار لحتى نحاول إنه نحد أو نقلل أو حتى في بعض الأوقات إنه نوقف التسوسات. ولكن في بعض المرضى في بعض الحالات نحتاج استعمال بعض الأدوات الثانوية اللي بتساعد على بقاء الأسنان بطريقة بشكل نظيف، لأنه في بعض الحالات فرشاة الأسنان والخيط غير كافي وما بيقدر إنه يوصل لبعض المناطق. تمام. That's why we need an interdental cleaning aid. First aid is an interdental brush. هاي البرش تيجي مثل it looks like the regular toothbrush that we use، مثل تيجي على بأحجام مختلفة. it has different sizes. بس تيجي شكلها شوي غير، شعيراتها شوي غير عن الفرشاية المتعودين عليها بالأسواق. تنباع بجميع الصيدليات، متوفرة في جميع الصيدليات بكل الأحجام. بتيجي single cone shaped brush. هاي الفرشاية بتكون كتير مفيدة للpatients with wide interdental spaces. في بعض المرضى بيكون الأسنان مو ملاصقة لبعضها البعض وبنفس الوقت يعني في فراغات بين الأسنان، وهاي الفراغات غير كافية إنها تدخل شعيرات الفرشاة الأسنان بين هذه المنطقة وتنظفها. وكمان خيط الأسنان بيكون غير مفيد في هذه المناطق، لذلك بنفضل إنه البيشنت إنه المريض يلتزم إنه يشتري هاي نوع من الفرشاة الأسنان، فممكن إنها تسهل حياته. Moving on to another interdental cleaning aid is the single tufted brush. هاي التوث برش تقريبا كمان شكلها قريب نوعا ما من فرشاة الأسنان الطبيعية، بس بيكون هي single tufted، تكون هيك شكلها. هاي بننصح المرضى اللي عندهم areas of malalignment. في بعض المرضى بتيجي عندهم ازدحام مثلا في الأسنان، في أسنان طالعة فوق بعض، صفة الأسنان مش مظبوطة، في عندي مثلا التفاف أو دوران شوي rotation in some teeth. ف in areas of malalignment single tufted brushes are beautiful and they help a lot in accessing such areas. Okay, so these areas are inaccessible with normal toothbrushing. Okay, we have mentioned the first way of preventing caries, and that was the primary prevention. Then we moved on to talk about the plaque control measures. The third way اللي ممكن إنه that helps in preventing caries إنه نحاول إنه نشتغل على العادات الصحية للمريض. تمام؟ زي ما كنا بنعرف إنه السكريات هي يعني أكتر شيء بتسبب تسوسات في الأسنان. So sugars are the and of course they are a major component of our daily diet. Although there are many risk factors for dental caries, the local effect of dietary sugars has a fundamental role in the disease. تمام؟ هلا وجود البكتيريا في حالات إنه عدم وجود السكريات ما رح يتكون تسوسات، والعكس صحيح. فإحنا بنحتاج لحتى يتكون التسوس نحتاج أكثر من عامل بيشتغلوا كلهم مع بعض. نحتاج tooth surface، نحتاج مايكروفلورا أو بكتيريا تسكن على هذه الأسنان مع غذاء لهذه البكتيريا اللي بيصير لها fermentation وبتتحلل هذا الأكل ليصير مادة أسيدك، مادة أسيدية تعمل لفترات طويلة. طبعا لازم هتضل لوقت طويل على سطح الأسنان، تعمل على تقليل المعدنة، خلينا نحكي للأسنان، and it demineralizes the tooth producing الإشي اللي الكل بيعرفوا اللي هو decay أو التوث caries. كيف ممكن نحسن من العادات الصحية أو الغذائية للمريض؟ هلا there are several dietary factors are associated with caries incidence. First of all, we care for the amount of fermentable carbohydrate that is consumed per day, the frequency of eating meals and the snacks. يعني اللي بيهمنا كمان احنا بيهمنا الكمية تبعت الكربوهيدرات اللي المريض بيستهلكها باليوم، ولكن اللي بيهمنا أكتر هو قد ايه الفريكونسي، يعني كل كم بياخد وجبة المريض، وكم الفترة اللي بضل هذا الأكل متراكم على سطح الأسنان. the length of the interval between eating the oral retentiveness، يعني length of the time teeth are exposed to decreased plaque pH, the form or the physical consistency with sequence of food consumption. هلا الفورم or the physical consistency طبعا لما يكون السكر مثلا بطريقة أكل ستيكي أو أكل بلزق على سطح الأسنان بيكون مختلف تمام تأثيره بعض الشيء على تكون التسوسات غير عن لما يكون مثلا جوس أو عصير. هاي different aspects اللي ممكن تلعب دور بتكون التسوس. تمام. طيب شو بننصح مرضانا؟ شو هي ال key recommendations? What are the key recommendations to modify the diet of patients? We advise the parents إنهم يوقفوا bottle feeding at 1 year. خلص لما يصير المريض الطفل عمره سنة واحدة إنه نحاول نوقف من الشرب بالرضاعات، و encourage الcup or beaker use. نصير ندخل الطفل استعمال الكاسة بدل من bottle feeding. Reduction of the non-milk extrinsic sugar. We need to limit the frequency of يعني sugary food. Avoid the grazing pattern. Snack low or non-cariogenic food between the meals. Avoid sugar-containing food close to bedtime. شو هي الأكلات اللي فيها anti-cariogenic effect؟ يعني هاي الأكلات بتكون مفيدة لحتى نوقف التسوسات أو إنها تمنع أو تقي من التسوسات. First of all, milk، الحليب. It contains lactose. هلا الحليب نعرف إنه هو فيه سكر ولا Okay, so we spoke about the sugar and we said how harmful is the sugar to the teeth, okay, in combination with microflora or microorganisms, specific microorganisms on a tooth for a prolonged period of time. Then comes the question of what are the sugar substitutes. في عنا بدائل للسكر اللي ممكن إنها تقلل من نسبة حدوث التسوسات. These substitutes examples عنهم أمثلة عنهم هم الزايليتول، المانيتول، sorbitol والأسبارتام. They found that they significantly reduces caries increments. okay, ففي دراسات كتير بتبين إنه هاي البدائل السكر بتقلل من تكون الكاريز. ليش؟ هلأ رح نتعرف عنها لما نتكلم عن الزايليتول. The xylitol stands out due to its anti-cariogenic potential. The xylitol carries preventive effects. شو بتعمل الزايليتول? How does the xylitol works in order to reduce caries and in order to prevent the occurrence of caries. الزايليتول كيف تشتغل أو شو هي الطريقة اللي بتشتغل فيها الزايليتول حتى اللي هو بديل عن السكر حتى يقلل حدوث التسوسات. First of all, it has a futile cycle. Sorry. That means it hampers the bacterial metabolism and reduces the pH decrease. احنا بنعرف متى بيصير في عندي تسوس لما ينزل ال pH، لما تنزل درجة ال pH وتصير acidic لما يصير ال pH بالأسنان حمضي، فهون بصير في عندي زي تحلل بالمينا تبعت الأسنان وبصير في عندي demineralization. So we know as the pH decreases, the more the reduction in the pH, that means it leads to more decay. So what the xylitol do is that it cuts the bacterial metabolism. So as a result, it reduces the decrease in the pH. So it maintains a good pH صحي للأسنان من دون ما تفقد المعادن اللي فيها. It also reduces the supragingival plaque due to the reduction of the extracellular polysaccharide. It promotes the selection of xylitol resistant bacteria. بتحاول إنه تختار selectively البكتيريا that are resistant to xylitol. هاي الأنواع من البكتيريا بتكون less adhesive، يعني قابلية التصاقها على سطح الأسنان قليلة وأقل، يعني مش كتير مؤذية. It is less virulent species and it stimulates the salivary flow. هلا we will talk about the saliva and how beneficial is the saliva in reducing caries. Okay, how do we use the xylitol? Well, what is the protocol and the recommendation for the xylitol use? شو هي طريقة إنه نستعمل الزايليتول حتى نحاول إنه نقلل من نسبة تكون التسوس؟ دائما بننصح الأطفال اللي هم أكثر من 4 سنوات إنه يستعملوا هاي الحلكة أو الشوينغم أو اللبان اللي بيكون فيه زايليتول. بنوصفه تقريبا للمرضى اللي هم high risk أو المرضى اللي هم caries active patients. هي علاقة الزايليتول بالكاريز ريدكشن هي dose response relationship، يعني كل ما زدنا الدوز كل ما زدنا الجرعة تبعت الزايليتول أو يعني الوقت اللي بنستعمل فيه الزايليتول فبنلاقي وقاية أكثر أو تقليل أكثر وملحوظ أكثر لتسوس الأسنان. So it's a dose response relationship. The more frequent you use the xylitol, the better response and the better results that you will achieve. 3 to 4 times per day with exposure time that is not less than 5 to 10 minutes. So at least 5 grams per day. ننصح باستعمال هاي العلكة أو هذا الزايلتول 3 إلى 4 مرات خلال اليوم، ويكون أقل شيء الوقت المضغ أو وقت العلكة من 5 دقائق إلى 10 دقائق. Now the dental health education. It's our responsibility as dentists, as dental hygienists, as assistants to educate patients and to increase the awareness about the oral hygiene and the dietary habits, and we need to try to change such aspects in our society. So the goal of the dental health education is to establish good oral hygiene and dietary habits. هو دور أطباء الأسنان والكادر الصحي كامل إنه يوعي المرضى والمراجعين بأهمية يعني أهمية تنظيف الأسنان وأهمية تغيير السلوك أو سلوكيات الطعام، أو يعني خلينا نحكي العادات الصحية للمريض حتى أو ننشر الوعي في هذا المكان. So the dental and the allied professionals have an ethical responsibility to inform patients about disease and how to prevent it. The establishment of needs-related oral hygiene habit requires a long-lasting motivation. We should motivate our patients, and it's not one time only, it's a long-lasting process and that requires a long-lasting motivation. So the motivational interviewing approach, we tend to go with this approach in order to motivate patients. Okay, so quick recap. We have talked about some of the preventive approaches that are needed in order or that are used and approved to reduce the caries occurrence, okay, the caries initiation. They were preventive approaches. We started by speaking about the primary prevention, moving on to the plaque control, and then we talked about dietary modifications. There's something that we should look at, which is the saliva. saliva أو اللعاب هو من خط الدفاع الأول لحتى يمنع التسوسات. Why? لأنه it has a lot of advantages. It has a digestive function. It has a remineralization function. It has a function of prevention of the demineralization. It has a function of lubrification, antimicrobial protection, and mechanical cleaning. So the saliva fulfills a major protective role against dental caries. What are things that stimulate saliva? يعني the most frequent and basic stimulant is the sugar-free gum. Okay, for example, here the recommendation is 2 pieces of chewing gum for more than 5 minutes after each meal would significantly decrease the risk of caries development. Okay, and we should keep in mind that there are some patients, for example, patients that are on antihypertensive drugs, they do, and other diseases as well, and there are other diseases and other pharmacological drugs that decreases the stimulation of saliva. Thus, this could affect the caries risk rate and the caries development in such patients. Moving on towards the remineralizing agents. There are some agents that try to remineralize the teeth. One of the most important and most significant in the industry is fluoride. Fluoride could be delivered in 2 ways, either systematically or topical. The systemic fluoride is by water, okay, or by tablets. We have now fluoridated community water by fluoride tablets and drops, or salt and milk fluoridation. The topical way is by professionally or self-apply. Professionally, that means inside the dental clinics, and self-applied at home. It is supplied by different delivery methods such as varnishes and gels, dentrifices, and mouth rinses. First, let's talk about the topical fluoride. We said that the topical fluoride is either a mouthwash, a toothpaste, or a varnish or gel. Let's talk about the mouth rinse. Now, usually the active ingredient in a mouthwash is either sodium fluoride or the APF. The frequency, if the mouthwash is to be used on a daily basis, we advise patients using the 0.05%, which contains 225 parts per million fluoride. If it was a weekly use, if it was for a weekly use, then we advise patients to use 0.2%, which contains 900 parts per million. We don't advise children under the age of 6 years old to use mouthwash, since such patients, they lack the not the dexterity, but maybe the reflexes are still not fully developed in order to help them use a mouthwash. Another antimicrobial agent is the chlorhexidine, but it is inconclusive. There are inconclusive evidence about caries preventive effects in children and adolescents. with regular exposure to fluoride. It may provide complementary strategy to in non-invasive management of high-risk patients. However, what is the disadvantages of chlorhexidine? First of all, and this is the most common side effect, is that it stains teeth, as we can see here. بيعمل على تسبغ الأسنان. It has a bitter taste, طعمه مر. It causes mucosal irritation. بيعمل زي هيجان في الميوكوزا, and it sometimes causes an allergic reaction. Moving on to the topical fluoride. The topical fluoride, if it was self-applied, that means it is supplied by toothpastes or any method that is delivered at home, then it is empirically recommended for which patients? For high-risk patients, okay? And such patients are the patients who are of special needs, reduced salivary flow due to medications or due to some diseases or any other cause, and wearing an intraoral prosthesis. Any intraoral appliance is considered as a high-risk patient. The toothpaste, okay, is the most beneficial and the cost-effective method for delivering fluoride to teeth, and there is a strong evidence for the benefits of daily brushing with a fluoridated toothpaste. What are the benefits? Okay, the benefit increases with having a high fluoride concentration. The frequency should be twice per day, and a supervised brushing. This is specifically for children. So there is also benefits for the primary dentition. معجون الأسنان لازم نهتم إنه يكون يحتوي على نسبة معينة من الفلورايد، وهو أسهل وأكثر طريقة متوفرة وسهلة لحتى نوصل الفلورايد على الأسنان. وزي ما حكينا إن مادة الفلورايد بتساعد على إعادة معدنة الأسنان وتعملها مقاومة للتسوسات. هلا توبيكال فلورايد، شو هو أنواع الفلورايد اللي موجودين بالتوثبيست؟ في عنا الصوديوم فلورايد، ستينس فلورايد and sodium monofluorophosphate. Going through the fluoride concentration، دائما بننصح إنه معجون الأسنان للأطفال يحتوي على 250 ل 500 part per million للفلورايد. طبعا الأطفال ما يعني تحت وما دون سن السنتين ما بننصح إنه يكون بالمعجون أو نستعمل له أي معجون يحتوي على فلورايد. أما بالنسبة للبالغين الأدلت toothpaste لازم يكون ما بين 1000 إلى 1450 between 1000 and 1450 part per million of fluoride. The fluoride toothpaste, to increase the fluoride retention following brushing. Okay, so in order to leave the fluoride the longest period ever and the longest retention on the tooth، لحتى نحاول إنه نخلي هذا الفلورايد يضل على سطح الأسنان لأطول فترة ممكنة، ننصح المرضى إنهم يعملوا السبيت نو رينز، إنه يحاولوا إنه يتمضمضوا، إنه يعني فقط يتفوا المعجون الزائد بدون ما إنه يحتاجوا إنه يغسلوا كثير الأسنان بالماء، لحتى نحاول إنه نخلي هاي طبقة الفلورايد على سطح الأسنان لأطول فترة ممكنة. So you avoid rinsing or excessive rinsing with water. okay, يعني ممكن إنه مضمضة خفيفة، ولكن نتجنب المبالغة في استعمال المي لحتى ما نزيل كل طبقة كل الفلورايد. Rinse with a slurry of fluoride toothpaste and rinse with a fluoride containing mouthwash. ممكن كمان إنه ننصح المرضى إنهم يتمضمضوا في غسول للفم اللي هو بيحتوي at least 100 part per million of fluoride نسبة التركيز، و non-fluoridated toothpaste at different times of the day. Moving on to the chlorhexidine gluconate. The studies have demonstrated significant reduction in the streptococcus mutants following the chlorhexidine therapy. إذا الكلورهكسيدين هو ما بيعمل على إعادة معدنة الأسنان على قدر ما أنه بيعمل it works as an antimicrobial agent rather than working as a remineralizing agent. فهو بيقلل من نسبة البكتيريا الموجودة في الفم. However, the clinical caries preventive effects were inconclusive. لسه الستاديز لسه الدراسات مش كتير، يعني ما عندنا كتير دراسات بموضوع إنه هل it prevents caries or not. So still the studies are inconclusive for the use of chlorhexidine gluconate. Okay, this is a repetition. We have already mentioned that. في طريقة ثانية إنها تكون لحتى نقلل من نسبة البكتيريا to decrease the bacterial population. Let's say إنه other than the use of the chlorhexidine gluconate is the usage of a probiotic bacteria. It is still a new method. It is يعني what is the probiotic bacteria? It's a non-modified bacteria that are naturally present in healthy individuals. Most of them belong to the lactobacilli and the bifidobacteria groups. It competes with other bacteria for nutrients and binding sites. Regular consumption is needed to maintain preventive and therapeutic level. The probiotics in dairy products show promising results, but further research is needed. زي ما حكينا هاي طريقة لسه جديدة and further research is still conducted to prove the efficacy of using probiotic bacteria in preventing or decreasing the development of caries. Something that is very promising and have been used a lot in pediatric dentistry nowadays is the silver diamine fluoride, or the SDF. It has a bifunctional agent. That means it has an antibacterial function and it has a hardening and remineralization of the remaining tooth structure. So it works at decreasing the bacteria levels as well as hardening and remineralizing of the remaining tooth structure. So it's very promising. Now, 96% for caries arrest and 70% for caries prevention. The SDF, it has outperformed all of the other caries preventive measures right now because, as we said, it is a bifunctional agent that works at decreasing the bacterial levels, and it works on hardening and remineralizing the remaining tooth structure. So it's very promising. كيف طريقة استعمال ال SDF أو شو هي recommendation؟ لازم تكون dry surface. We should have a dry surface and we should protect the soft tissues because it's harmful for the soft tissues, and the recommended dose is only 1 drop per 10 kilograms per visit of a 38% of SDF that is applied for a time interval between 30 to 60 seconds, يعني up to 1 minute, and it should be used twice per year. What are the indications for the use of silver diamine fluoride, the SDF? We tend to recommend يعني the use of SDF in cases of extreme caries risk for patients who are very high risk, extremely high risk, and patients who cannot tolerate the standard treatment, for example, young patients, and for difficult to treat lesions. For example, there are some lesions that are atypical, lesions that are around a crown margin, So these lesions, it is difficult to intervene operatively by drilling such lesions around crown margins and for partially erupted teeth. It is also indicated to control active disease in patients with multiple lesions. For example, such patient has multiple lesions, and the patient, for example, is a pediatric patient who cannot tolerate long sessions, who cannot tolerate drilling, who is, let's say, relatively uncooperative. So such cases, we do indicate the use of SDF because it hardens, it remineralizes, and it decreases the bacteria, as we have said before. And patients with poor access to dental care, patients who live in remote areas. However, SDF has some side effects and some adverse effects. It stains the caries, not the sound tissue. So it does stains the caries but not the sound tissue. It causes also skin stains. It causes it stains surfaces and the clothes. It has a metallic and a bitter taste. It causes somehow a mild gingival or mucosal response. There is a risk of a fluorosis, and there is a risk for silver allergy. Now, the seventh and the last way to prevent caries, or the last preventive measure, is to seal the tooth surface, especially for these teeth, such as premolars and molars, that have very deep fissures. Okay, so currently there is a bulk of evidence supporting caries preventive effects of sealants on sound surfaces as well as surfaces with incipient lesions. So what we do is that we fill such deep pits and deep fissures with a flowable resin or a GIC, glass ionomer, cement, in order to stop an incipient lesion or to prevent the formation of a lesion due to the stagnation of food and bacteria in such deep fissures, okay, which are not accessible for the toothbrush always. Fissure sealants, the lesions effectively sealed should not progress, and the sealing lesions significantly reduces the bacterial levels, and this affects the increase over time. Okay, there is always a debate on should we use a resin or a glass ionomer sealant. Now, it's still inconclusive. There are still inconclusive evidence regarding the caries preventive effect. However, resin sealants must remain the first choice material when cooperation is sufficient and moisture control is attainable. Usually we do advise dentists to use the GI sealants in cases where, for example, in such cases where the tooth is partially erupted, there isn't a good cooperation, because as we know that resin is very sensitive to moisture, and we need a good moisture isolation around the tooth. The patient is so young and the cooperation is not very excellent. In areas where in areas of poor isolation, in cases of partially erupted teeth, uncooperative young patient who could not withstand any moisture isolation method from cotton rolls or rubber dam. So in such cases we can go for the GI sealant, the glass ionomer sealant, and maybe later on could be replaced by resin or any other material, for example. There is another technique that is suggested by Hall technique. It's a new method that suggests covering the tooth by a prefabricated metal crown. This is a simplified biological rather than a surgical management. We're trying to deal with and manage caries rather with sealing the caries lesion, the carious lesion, rather than drilling and filling, okay? This is used basically for primary molars, okay? Using a prefabricated metal crown, the stainless steel crowns that we know. It has proven that it is significantly higher than a 5-year survival rate compared to the conventional intracoronal restoration such as class 1, class 2. Okay, so what we're doing here is that we're trying to isolate the tooth or the carious lesion from all the other factors, the external factors surrounding the tooth, from bacteria and fermentable sugar and saliva and all the other factors that we have mentioned before. Still, it's not widely used, but I guess it's a promising technique to be used, to be honest. There are new methods that are still under studies and still not 100% يعني proved, such as lasers, genetic modalities, caries, vaccines, and active and passive immunization. So by that, I believe we have reached the end of the lecture. I hope it was very beneficial and informative as well. I would like to thank you all for bearing up with me and keeping up with me till the end of this lecture. I also apologize for any mistake that or any